I'm Tara Mastracci from the Royal Free Hospital. I'm a vascular surgeon, and I'm speaking to you today at the London Aortic Symposium 2018. We're really excited about the event this year. It's the 4th annual event, and this year we decided to make it a truly multidisciplinary meeting. We've invited trainees from the radiology schools and the anesthesia schools, as well as vascular surgery, acknowledging that aortic care is really important as a multidisciplinary team. And it's something that we wanted to reinforce, both in the audience and in the talks that we've prepared. Yesterday I was asked to give a talk called "The IFU is not a clinical guideline," and it was a bit of a controversial talk. But we wanted to really provoke the audience and make the trainees think about what considerations they have when they're implanting devices in the aorta. So the IFU obviously originally was a regulatory mandate, and it's something that kind of describes the boundary conditions that the engineers use to test devices. But ever since Chancer and Greenberg's paper in circulation, it's kind of been set as a benchmark for the gold standard. But unfortunately, it doesn't kind of tell us the whole picture. And it's important to make sure that we really look at what the patient characteristics are and what the aortic characteristics are before we choose the device or the modality for treating aortic disease. Pivotal trials that companies run to get devices marketed really have very short-term outcomes. And as we can see from the NICE guidelines, our practices are being tested based on durability and much longer-term outcomes. So I think it's important that we keep this in mind when we're implanting devices, which means looking well beyond the IFU into our vascular training to decide what's best for a patient. I don't think there's anything that can guarantee a device will last forever, because we know the aorta continues to degenerate over time. So whether it's open surgery or endovascular surgery, patients who live long enough are going to be prone to developing another aneurysm and therefore need a reintervention. I don't think this is the fault of any device. What we will be faulted for is not thinking ahead and planning ahead. And so it's really important to plan repairs that last as long as possible, but if they're going to fail, they fail well. I think the most important thing is to audit your own center's data and make sure that you understand when devices you've implanted have failed and why they've failed. So being really introspective and self-evaluatory is probably the best thing we can do for device durability. Once you've done that, as many of us have, what you learn is that longer landing zones are better. Younger patients may do better with open surgery, but will still require an endoconversion in the future if they live 7 years. And in endovascular cases, if they fail, we'll need nice long landing zones within them so that they can be converted. So it's just a matter of picking up these lessons from auditing your own practice over time.